Hello, I am Jan Lathman.
And I am Muskan Joshi.
Welcome. Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote presentation by Dr. Luis Raez. Dr. Raez is the president of the Florida Society of Clinical Oncology, or FLASCO, the chief scientific officer and medical director of the Memorial Cancer Institute, and also the co-director of the MCI FAU Florida Cancer Center of Excellence.
In today's presentation, Dr. Raez discusses the latest updates in the development of biomarkers for lung cancer therapy.
Did you know that Dr. Raez has designed and led many phase 1, phase 2, and phase 3 clinical trials with new targeted agents and immunotherapies against lung cancer?
He truly is a pioneer in the field of lung cancer.
So let's tune in and learn from this global leader.
So now we're going to talk more in the right side. Most of the patients don't have the genetic aberrations, so we need to do other biomarkers to give us orientation. So the problem that we have nowadays with immunotherapy is people asking me, why you still use chemo? Why you still use chemo and now we have immunotherapy? The problem is that the immunotherapy is great, but that doesn't work forever. So the immunotherapy can cure more than 20% of the lung cancer patients, even in stage 4. The immunotherapy, unfortunately, like after 1 year, half of the patients progress for the ones that don't get cured. That's why it's good that you get cured, but it's very few patients. Most of the patients only enjoy the immunotherapy benefits for 1 year. What happens is we have tumors that we call hot in red, tumors that have a lot of lymphocytes, cytokines, So there are tumors that respond to immunotherapy. We have tumors that are cold, tumors that don't respond to immunotherapy, or we call them immunodisturbed tumors. And then we have tumors that were responding to immunotherapy, and then they exclude themselves. They become resistant. The problem is we don't have a way to identify them. What we do in immunotherapy nowadays is we give to everybody. We give immunotherapy to everybody with chemo, and then we find, which ones respond, which ones don't respond. But that's not a very good way to do precision medicine, but that's the best that we do. So what we have to do here is more or less the future. So instead to give conventional immunotherapy with a low benefit, and I don't want to be pessimistic, what happens is if you only give immunotherapy alone, only half of the patients respond, only 20% get cured, and the rest of the patients in 1 year, half of them fail. So that's why we call them low benefits. It's not like I'm being pessimistic. We want to use immunotherapy and cure everybody. That will be the goal. So that's why we need to use other strategies, because these patients don't have genetic markers, genetic aberrations. So we need to use other biomarkers. And so that's why, for example, in green, you see we have patients that have a high TMB, high tumor burden, or are MSI high or MMR positive. Okay, that can be a good biomarker. If you have a high TMB or MSI high, pembrolizumab is already approved for these 2 indications by the FDA. Unfortunately, they're not very common. For example, in lung cancer, very few patients have MSI high, and very few patients have high TMB. And one of the problems that we have, for example, with the TMB is that the study that approved the TMB had a very few lung cancer. So that's why even if it's FDA approved, we don't feel comfortable. But that's one way that we can use a biomarker to say, these patients will respond to immunotherapy. But then another option is, for example, in yellow, one of the reasons why we believe that patients don't respond to immunotherapy is because there are regulatory cells that are overexpressed. And these regulatory cells don't allow immunotherapy to work. Or they were allowing immunotherapy to work, and 1 year later, they decided not to allow immunotherapy to work. And these are called Tregs, or they are called MDSCs. There are many types of regulatory cells. So what we have to do is we have to give the immuno plus something to shut down these regulatory cells, or something to overcome the expression of these regulatory cells. That's what we call immunoadjuvant. Okay? And so that's why this is another potential strategy, and we have a lot of research projects now ongoing when the patients fail conventional immunotherapy, we give something to shut down the regulatory cells, and then we put back the patient immunotherapy. We have a lot of clinical trials in the United States about that. And the same with the other options. No? We use neoantigens to activate a cold tumor in purple. Or finally, if we have a tumor that don't have lymphocytes, it's probably totally immune excluded. Okay, that's a patient that we don't need to use immunotherapy. We don't need to be using $100,000 a year therapy empirically to see just in case if the patient works. That's not also good utilization of resources. No, but these are rational strategies that we need to apply in real life to improve the activity of immunotherapy. So PD-L1 is the biomarker we are more familiar. As I said, it doesn't make us happy, but it's better than nothing. So the problem with the PD-L1, as you know, there is intra-tumor heterogeneity. Depending where you put the needle, the PD-L1 can be negative, positive, high, or low. That's why it's not very reliable. The PD-L1 change from the side. So if you have a patient with lung cancer with metastatic disease, depending on what do you biopsy, the original tumor or the metastasis, for example, in the adrenal, in the liver, or in the brain, the PD-L1 is going to be different. So that's why it's not reliable. And then the PD-L1 change with treatment. So that's why it's depending when you're doing the analysis of PD-L1, it may be different. So that's why the PD-L1 is not a good marker. And the other complicated thing, if you remember, is we have now 5 agents approved for immunotherapy in lung cancer, that each pharmaceutical company developed their own PD-L1 antibody. Because now you cannot ask any hospital in the world to buy 5 drugs and 5 antibodies to test for each of them. So that's why this blueprint project that was done by the SLC, International Association for the Study of Lung Cancer, was great. It was a harmonization project that said basically, to make the story short, all the antibodies are equivalent. Yeah, so you don't need to test for all of them. Ventana 142, as you can see in blue, was not as accurate as the others. This was for atezolizumab. However, people that develop atezolizumab also use the antibody called SP263, and you can see in the graphic, 263 is compatible with the other antibodies, so this is no problem. If you want to use atezolizumab, you have 263 for testing. So that's why now we feel more comfortable that we don't have to be buying a different clone to test for PD-L1, that whatever test we do is accurate. And the most common use of PD-L1 as a marker is for patients that have PD-L1 more than 50%. And as you can see, based on Keynote 024, in this study, it's very important study. It was the first time that in patients that with lung cancer, that the PD-L1 is more than 50%, we were able to prove that we don't need chemotherapy anymore, because in this study, it was matched pembrolizumab against chemo. And even the patients that got the chemo, they had opportunity, if they failed, to go for the pembro. And even like that, there was a survival benefit. This is not the original publication. This is the 5-year update that Dr. Bremer did in ESMO. You can see it's amazing that at 5 years, 60 months, they practically were duplicating the survival of these patients compared with palliative chemotherapy. I know this is not as exciting as a presentation of breast cancer or lymphoma that probably you cure many more people, but for lung cancer, if you see going from 16% to 31% survival at 5 years, and probably after 5 years, these patients are already cured, is very exciting for us with only immunotherapy, with replacing the chemo as a front line. The second utilization that is popular with the PD-L1 is when the patients are PD-L1 positive, more than 1%. Based on this study, Checkmate 227, we know that you can use the combo, immunocombo, nivolumab with ipilimumab. No, that's another strategy with no chemo. Ipi-nivo, this combo called ipi-nivo, is better than chemo for new patients with stage 4 disease. And as you can see here, this is the 3-year update. There is an improvement in 10% in the survival if we use the ipi-nivo instead of chemo. And then the patient don't have to go through all the side effects of chemo. And it has to be for PD-L1 more than 1%. So that's why for practical applications for the PD-L1 today, if it's more than 1%, you can use ipi-nivo based on this study. If it's more than 50%, you can use the pembrolone, atezolone, semiprimavalone. No, these are the practical applications for PD-L1. We don't have any more use of PD-L1. The other marker that is popular is, well, popular or known, but we still don't have a standard use, is tumor mutation burden. So tumor mutation burden, you know, is higher in melanoma, lung cancer, pancreas compared with AML, thyroid cancer. So that's why, because these tumors are more immunogenic, so they have more antigens. And of course, as more immunogenic is the tumor, more antigens, higher tumor mutation burden, the chance to respond to immunotherapy is higher. And, you know, there are a lot of publications about tumor mutation burden. This is one that we did, led by Dr. Spiegel. We did this from Foundation Medicine many years ago. Basically, the first group of patients that we treated with immunotherapy 5-6 years ago, we grew 64 of our patients in 5 centers, and we measured the tumor mutation burden, and we divided more than 15, less than 15, and we found that it's very reliable. So you see, the tumor mutation burden is more than 15. Patients have a much better response and survival with immunotherapy compared with the tumor mutation burden that is less than 15. We tried to do that for 12 and it didn't work very well, so we ended with 15. But the problem is that everybody has their own way to check tumor mutation burden. So I'm not going to go for details because we don't have time, but the way that we calculate the tumor mutation burden is very subjective. Some people does in a small number of genes, some people does in the whole genome, some people does in the whole exosome. It's not the same thing, and there is no harmonization. As you can see, these are many examples of how we calculate tumor mutation burden. The cutoffs are in the right, they don't even look too similar. So that's why it's hard. Until we have an harmonization in how we do tumor mutation burden, we are very limited in the use of tumor mutation burden. And tumor mutation burden and PD-L1, as you can see in this table, do not correlate. Not because you can say higher mutation burden, higher PD-L1 makes our life easy. Don't correlate. Of course, the tumors like in the right that have a high TMB and at the same time have a high PDL, you know, you have two biomarkers, so the patient is the best of all worlds, you know, but they don't correlate. And once in a while, we have a study positive, like this MYSTIC study, when we analyze the PD-L1, comparing chemo versus immunotherapy, it was negative. However, when we did the analysis, you can see in the left side, with tumor mutation burden, apparently, if the tumor mutation burden is more than 20, patients with immunotherapy can do better than with chemotherapy. But this is not standard of care. This is a retrospective analysis, you know, not a prospective analysis. So that's why the tumor mutation burden may work, like the PD-L1, but it's not accurate yet, and it's harmonization. Yeah. However, as you remember, based on this study, Keynote 158, tumor mutation burden for practical purposes is approved in the United States since August 2020 in solid tumors that have failed standard therapy as long as the tumor mutation burden is more than 10. So there is a practical utility to use tumor mutation burden, but it's very uncommon, at least in lung cancer, to find a lot of patients that qualify for this. And as I said, this Keynote 158 have very few lung cancer patients. That's why we don't feel very comfortable with this approval based on and it's not a randomized study. This approval, I think, is stronger for uterine carcinoma, colon cancers, because in this study there were many more patients with these tumors and not with lung cancer. There are other potential biomarkers. So in other words, to finish the talk, I want to mention briefly what other biomarkers, because as I said, we are not happy or we are not satisfied with PD-L1 or TMB. There has to be other biomarkers. So I want to mention briefly some of them. One of them is the cell-free DNA. So we can measure with liquid biopsies, not only identify the genetic aberrations, but we can also check cell-free DNA. So in other words, we can check what is the amount of tumor bulk in the DNA, in the liquid biopsy. So for example, in the left, you can see that patients that have a high baseline cell-free DNA, like in yellow, they have a shorter survival compared with have a patient with more cell-free DNA in blue. And that makes sense, you know, more tumor you have in the blood, I guess, less chance of survival. The same in the right, they say the same experiment with circulating tumor cells. If the patient have a present circulating tumor cells the chance of survival is inferior compared with the patients that don't have circulating tumor cells. But these are small studies. So ideally, maybe this is I like this study because it's a good example of a trial in the near future. Instead of be treating empirically everybody with the same, we can start, for example, patients with ipi-nivo. Remember, ipi-nivo is approved for more patients with stage 4 more than 1%. And we can monitor the DNA, the cell-free DNA, the amount of tumor. So if the ipi-nivo, this immune strategy, doesn't work because the tumor DNA is increasing in the bloodstream, we can intensify the therapy and add, for example, chemo. However, if the ipi-nivo is decreasing the amount of tumor DNA, we can stay with immunotherapy and we don't need to intensify the treatment. So this is a dynamic way where we can use a biomarker to monitor the tumor and check the clinical outcomes. And this is something that we do. We know, I haven't mentioned, pretty much everything I mentioned is DNA, but we also have to remember that we also have RNA. And until recently, it was very hard to work with RNA because it degrades very fast. Nowadays, we have the technology to keep the DNA stable so we can track it. So basically what we do, for example, our group does liquid biopsies, and we track exactly the same as I mentioned in the previous slide. We track clinical outcomes, failure, progression, response with RNA in the blood. So for example, in the upper left, if the patient fails treatment, there is progression in red, the amount of PD-L1 measured in the RNA goes up. If the patient responds in blue or light blue, the amount of PD-L1 in the blood based on RNA done by RT-PCR, it goes down. That is the same thing that we're showing in the left bottom, and the same thing we're showing in the right. In the right, basically, we're tracking KRAS tumors with DNA in blue and comparing the responses, and we're tracking in red PD-L1 by RNA, and it seems to be more accurate than the DNA. No, that's what we think. We're not trying to say RNA is better, but I'm saying it's a very good option that is not well utilized. Most of the platforms for liquid biopsy and biomarkers are only based on DNA today. The same thing here. These are patients that let's focus on the right. This is a patient that is on immunotherapy, lung cancer immunotherapy. You can see that the PD-L1 expression measured by RT-PCR in the blood goes down during treatment and then gets stable as long as the patient is stable. How we know the patient is stable? Because we're doing CAT scans. How we know the patient has a partial response? We're doing CAT scans. So we're comparing CAT scans with a blood monitorization, in this case by RNA, and there is correlation. There is a good correlation. And so that's why we are proposing this biomarker for the future as a one way to correlate with clinical responses. And there are other biomarkers. For example, this is another group that is doing as PD-L1. Remember, I mentioned I do PD-L1 in RNA. This group is doing PD-L1 in circulating tumor cells. And as you can see in the right, it correlates if the circulating tumor cells are present and they are not present. You can see how the prognosis is different. And finally, maybe going back to the genetic aberrations, maybe the presence of certain genes can confer bad prognosis or can be a negative predictive factor. For example, STK11 or LKB1, there are many groups in the world that have shown that you can focus on the right, the survival of patients treated with immunotherapy, if you carry the mutation STK11 in orange, is inferior. Is inferior compared to the patients that don't have that genetic aberration. But this thing is more complicated. If you look in the right, upper right, if you have the STK11, but at the same time you have a co-mutation with KRAS or KRAS, you have a good prognosis. So that's why it's complicated. Yeah, because in this specific case, the co-mutation protects when STK11 is alone, is detrimental. So maybe we can use these new biomarkers to guide us treatment. Maybe in the future, if the patient has STK11 aberration, should not have immunotherapy and not waste the patient's time and toxicity and morbidity unnecessary. But we need to make this more accurate. This is not standard of care yet. Finally, early stage tumors. These are patients post-surgery. If we find circulating DNA, circulating tumoral DNA after the surgery, of course, the patient is going to relapse. You can see the survival in the orange. If we don't find it, we think the patient is cured because after the surgery, there is no tumoral DNA. Makes sense. The patient is probably cured. You can see in black, the survival is flat. Same thing here. And this is by stage. So if you find circulating tumoral DNA after surgery, the prognosis is worse if you don't find it. This should become a standard of care for all the tumors, not only for lung cancer, because it makes a lot of sense. What happened is before we didn't believe on this because the technology was not accurate. Now we're making the adequate technology to discover what we call MRD, minimal residual disease. So it's only a matter of time before we start to do this in every single tumor after surgery. And this is another example. I want to skip. Finally, in the last two slides, the best use of biomarker is prevention. These are screening charts. If you can see, breast screening, cervical screening with pap smear, lung cancer screening is in purple. And if you don't see it, it's because it's so bad that you don't see it because it's in the bottom of the table, you know. It used to be there 1.2%, now it's only 4%. So it's still in the bottom. So meaning only 4% of the patients that qualify for lung cancer screening in the United States, that are 15 million, only 4% are screened, the other 96% are not screened. So it's going to take many years to adopt lung cancer screening by CAT scan. Maybe there has to be an easier way to do that. And this is one of the proposed easy ways. Okay. You know, methylation, these CH3 radicals damage the DNA. Yeah, so we know that for many, many years. One way you damage the DNA, in the promoter region, you attach a methyl and you damage the DNA. So we believe that if there is methylation of the DNA, we have a precancerous condition. It's only a matter of time. As more methylation happens, the cancer is going to come. So now there are groups and publications. This is one of the publications, recent publications about methylation, showing that if you see, for example, in the upper picture, the normal DNA is not, the methylation is minimal in purple. If you see in the bottom, this patient is a lung cancer patient. The DNA is methylated tremendously. Because based on these models, maybe we can predict if I draw blood in a 60-year-old smoker and I found a pattern like the patient in the bottom, I can predict that maybe this patient is going to have lung cancer, way below we start to see anything in the CAT scan. So that's the future of the biomarkers. The biomarkers are not only for stage 4 patients that we use now, they are not only for diagnosis. I have shown you that the biomarkers is to be done at several points during the natural course of disease. And for me, the most exciting point is that maybe these biomarkers are needed way below the cancer is seen, so we can prevent and do something to avoid the cancer, or at least we can catch these cancers in its early stages so we can cure these patients instead to do palliative therapies. Thank you for your attention.